So let's look at this chart. It's to help visualize the comparison between type 1 and type 2. I know this is confusing considering I told you that the PR interval includes all structures participating in the onset of the P wave to the onset of the R wave, which we said was from the AV node to the Purkinje system. But stick with me for a second. It is a helpful way to differentiate in your mind the difference between type 1 and type 2. Type 1 has a progressive lengthening or progressive prolongation of the PR interval before we drop a beat. So because number 1 is a higher ranking, if you're following college football or college basketball or whatever you want to call it, we must know that because it's higher up in the ranking, so number 1 is higher than number 2, then this must occur somewhere higher. If this is our conduction system, it must occur somewhere higher in the conduction system, which is what is the case in the which is what is going on in the case of Mobitz type 1. Mobitz type 1, there's a problem within the AV node that's higher up the conductive system of the heart. So imagine this is our ventricle, and this is the AV node here, and then this is our his, and this is our left bundle branch. This is our right bundle branch. Now the number 2 ranking obviously comes after the number 1 ranking. So type 2 must be due to some problem after or below the AV node. Again, we just said that Mobitz type 2 was a problem within the his bundle or one of these bundle branches. The AV node is perfectly fine, which is why the PR interval remains constant. But we still drop a beat because there's a structural abnormality within the system directly to the AV node that is just still required for conducting that beat to those ventricular myocytes. So we lose a QRS complex while maintaining our PR interval because the AV node is fine. So these structures under the AV node in type 2 block will lose the ability to transmit the signal from the AV node further down to the ventricular myocytes, so the ventricles will not be stimulated at all. This occurs in a 2-to-1 ratio, which means that you will have a P wave that does not get conducted to the ventricles, followed by another P wave, giving you your 2 P waves, and you only get 1 QRS complex because you dropped one of those beats. Again, we can see down here that this is our Mobitz type 2. P wave is the same, PR interval is the same, and then all of a sudden, boom, no QRS complex. Boom, no QRS complex. So the anatomic site of block for type 1 is the higher ranked, higher up in the conduction system, if we're talking more superiorly, AV node in type 1, and then in type 2, it's when the his bundle or the bundle branches have some sort of fibrotic change. And it's usually due to ischemia, because remember when we have ischemia, the cells die, and the only way the heart can heal it is with scarring. There are no stem cells in the heart. Another important thing to note is that Mobitz type 1 is usually asymptomatic, while Mobitz type 2 will usually progress to 3rd degree block, which is really bad because the scarring will cause conduction abnormalities to the point that eventually you just have complete dissociation of the atria to the ventricles. And this is usually due to the fact that if you had ischemia once, you probably still have the underlying coronary artery disease that caused that ischemia. So it usually progresses, because this disease is usually pretty advanced if you are presenting with type 2 block. Now, let's continue with the 3rd degree. We have reached the last type of AV block that we are going to discuss. We discussed how type 1 Mobitz was a dysfunction of the AV node, and type 2 Mobitz was an abnormality of the structures directly under the AV node, the bundle of his, or common bundle, and it can also potentially be the bundle branches themselves. 3rd degree block is a severely diseased version of either one. So you have type 1 Mobitz or type 2. You get really bad fibrosis because you have continued ischemia, because that's how you got to where we are in the first place, and then that'll lead you to 3rd degree block. A 3rd degree block is a severely diseased AV node, his, or also named common bundle, or the origin of the bundle branches. Do you think there will be any stable chronological relationship between the P and the QRS complexes? Well, if you completely abolish the communication between your atria and your ventricles due to fibrosis, fibrotic tissue cannot conduct depolarizations. Abolish this, there will be no way you can have coordination between the two, unless you have an accessory pathway like a WPW, which would be actually a good situation for one time. How do the ventricles depolarize without any impulse being able to transmit from the atria at all in 3rd degree block? Do you remember how I told you that the Purkinje fibers could display some automaticity and they would depolarize at a rate of 20 beats per minute? Well, just like we said here, 3rd degree block is progression of fibrotic disease of the AV node or the his bundle branch myofibrils. His bundle branch myofibrils. So if the AV node or the His bundle branch myofibrils do not transmit the normally much faster depolarization from the SA node to the structures in the ventricles, then your ventricles are going to create some sort of electrical signal to depolarize your ventricles. The atria will depolarize in response to the normal SA node, so this is all normal up here, while the ventricles are going to be told what to do by some escape or ectopic beat within the ventricular structures themselves. And that will normally be a Purkinje fiber first, and that will be setting an intrinsic 20 beats per minute baseline, while we know that the SA node sets a 60 beats per minute baseline. I don't know about you, but these numbers don't look very similar to me. 60 and 20 beats per minute are completely different things. This creates a complete dissociation between the atria and the ventricles, so there is no discernible relationship between the P waves and the QRS complexes on your ECG tracing. Examples of this are in the tracing on the slide and in your Step 1 book. The P on T wave phenomenon should make a lot of sense because your Purkinje cells are setting the baseline depolarization rate in the ventricles, while your SA node is setting the baseline depolarization in your atria. So you can have a superimposition of the P wave on top of a T wave. You can also have a P wave on an ST-T complex. An ST-T complex is just another way of talking about repolarization because it can sometimes be difficult to determine where the ST segment ends and the T wave starts on the ECG. So let's check out this ECG tracing. As you can see, there's no relationship at all between our P waves and the QRS complexes. They're just randomly spaced out everywhere, to the point where you can even have abnormalities where you can't even discern what's going on at all. So here's a P wave, here's a P wave, oh, there's a little QRS, here we have a P wave trying to start, here's a P wave, there's another QRS, here's a repolarization wave, a T wave, here's an it's just everywhere. The ability of us to read this ECG is very limited because it is not normal, and there's no consistent pattern between the two. The atria and the depolarization of the ventricles are completely off. Okay, let's take a break from the ECG tracings and discuss two incredibly important peptides that are associated with a natural response to increased volume and pressures in the heart. These peptides are released from the atria and the ventricles. We will begin with the discussion of atrial natriuretic peptide. First of all, just look at the name of this peptide. Atria indicates it's released from the atrial myocytes. Natriuretic is defined as the excretion of sodium in the urine. Natri, N-A-T-R-I, means sodium, and uretic means through the urine. And peptide, obviously, that is the structure of the molecule we're discussing. So basically, some peptide released from the atrial myocytes will cause the eventual elimination of sodium in the urine. Atrial natriuretic peptide is critical in the aldosterone escape mechanism. Now, we hear this all the time. What does it even mean? First, we need to understand the renin-angiotensin. Aldosterone system and how it can contribute to the downward spiral of heart failure before we can see how we can escape with it with this ANP or atrial natriuretic peptide. Okay guys, this is super important. You better know the RAS system. You will hear it again in your renal physiology chapter. Let me first start with some reasons why you would activate your renin-angiotensin aldosterone system. We are in the cardiology section, so my focus here will be mainly on how the heart can contribute to the activation of the renin-angiotensin aldosterone system. After that, we will see how we can counteract some of the RAS activation with atrial and brain natriuretic peptides. So I'm going to start with a vignette summary, then show you how the Step 1 examiners want you to connect your knowledge of the RAS system, heart failure, and the body's ability to counteract this downward spiral of heart failure that the RAS system can be with chronic activation. So let's say a 48-year-old white female comes to you with a 6-month history of lightheadedness, palpitations, and a sensation that her heart is fluttering away. She recently became more concerned when her son in medical school listened to her heart when he finally got that first stethoscope in the mail. Let's all remember that moment for a second. Her son heard a systolic murmur in the 5th intercostal space, somewhere around the mid-clavicular line, and it increased on expiration. Her past medical history, PMH, is significant for a long history of mitral valve prolapse. It's a quick summary. 48-year-old white female 6-month history of lightheadedness, palpitations, sensation her heart is fluttering away. Auscultation was a systolic murmur in the 5th intercostal space at the midclavicular line, increased on expiration. She has a past medical history of mitral valve prolapse. What does this mean to us if we are in step 1 beast mode? Well, we know that this murmur sounds like mitral regurgitation because it is occurring in systole in the mitral area, and because all left-sided murmurs except mitral valve prolapse and hypertrophic cardiomyopathy increase with expiration. Remember, expiration compresses the structures in the thorax. Particularly, it would also help compress that left ventricle and help eject some volume. And whenever you help that left ventricle eject volume, you can get more flow across that incompetent mitral valve. So this is mitral regurgitation. So this woman has been suffering from chronic regurgitation of blood into the left atrium across an incompetent mitral valve. We're going to call this chronic volume overload because that regurgitated blood will then be pushed back into the left ventricle. So again, the left ventricle, incompetent mitral valve, more blood into that left atrium, and then eventually we're just going to put it right back into that left ventricle, and then we're going to regurgitate it right back. Over time, this will dilate that left atrium. This large volume of blood that we continue to regurgitate and then pump back in will try to distend the ventricle, creating a considerable amount of wall tension. How does the left ventricle react to this? Well, if we have a lot of wall tension because the chamber is trying to be distended, the myocardium will compensate. It'll compensate by adding sarcomeres in series, so it adds them end on end on end on end. Not only does this increase the thickness because we're adding sarcomeres, which are mass, this also allows our ventricle to dilate because these are just like adding stretchy rope end on end to each other. So now we're going to have a thicker walled ventricle that's also more distended. This is our friend the law of Laplace showing up again. The volume overload has created an increase in the wall tension. Remember, the law of Laplace is wall tension equals pressure times what? The radius divided by wall thickness. So we compensated by not only thickening the ventricular wall by adding sarcomeres in series, but we also increased the radius of the chamber because adding those sarcomeres in a big line will allow for more distension of the chamber. So again, we can push this out even further. I did a poor job of drawing that. But just imagine how this chamber will now be able to push itself much larger because we added more slack, essentially, by adding those sarcomeres in series, like tying ropes end on end. This is called eccentric hypertrophy because we increase the ventricular wall thickness while also allowing an increase in the radius of the chamber. The actual definition of eccentric is deviating from a circular form or path, which should make sense because that's what we're doing. That's what's going to happen to our chamber if we keep on dilating it. It is just going to keep on dilating until eventually it just becomes a big, floppy, crappy ventricle, like a Walmart bag in the wind. For the sake of review, what is the other type of hypertrophy that we will also discuss later? Concentric hypertrophy. Remember, concentric hypertrophy is due to a pressure overload, where we need to increase the mass of this ventricle and ability of it to contract by adding sarcomeres in parallel, which will increase the myocardial wall thickness while also preventing the chamber from dilating because we're adding sarcomeres in parallel towards the center of the ventricular chamber. And that means we have a very low volume capacity to allow blood into our ventricle. Okay, we reviewed the important concept of the law of Laplace twice now. Make sure you know that concept. It'll really help you later on. Now, how does this eccentric and concentric, whatever you want to call it, how does this relate to the activation of the renin-angiotensin-aldosterone system and the natriuretic peptides? Do you think that a big floppy ventricle will be able to pump forward very well? Absolutely not. Do you think that a ventricle that is too thick and hard will be able to fill with enough blood to forward perfuse the rest of the organs, particularly the kidney? Absolutely not. Kind of let it go just a second ago, but guess which organ that is an important mediator of the renin-angiotensin-aldosterone system will not be adequately perfused by the heart when it is suffering from either systolic or diastolic dysfunction? It's right here, the kidney.